Good evening, everyone. Welcome along. Just do a sound check. Just somebody throw in the comments whether you can hear me at all. Lovely. Thank you very much. Perfect. Good to hear. Welcome along. Good to see so many of you here. Yet again, week number 4 now. Can't believe how quickly it's going in our free and interactive webinar series. So good evening to you. I'm just having a look through the guest list there, and there seems to be quite a few familiar faces. So that's good to see you back. I'm glad they're useful for you. And hopefully tonight will be even more so. I think this is a subject that we all get quite interested in, and I think it's primarily one of the main reasons we do ECGs, isn't it, to look for signs of the acute coronary syndromes, in particular heart attacks. So absolutely. So I'm just going to pause for a few seconds. There's quite a few people just coming in, so we'll just give a few minutes before we run on ahead as usual, just for the late runners. So yeah, as I say, 4th in the series of free and interactive webinars this evening on acute coronary syndromes. Good evening, everyone. Lots of chat going on. Great to see you all. Welcome along. Thanks for coming. And quite a few of you from all over the place tonight. Scotland and Wales represented. Lovely. That's good. Fabulous. Still a couple more just coming in. Great to see so many again. So for those of you that haven't watched these before, I'm Innes. I'm a paramedic practitioner. I work in a GP surgery by day and bank shifts with a couple of the ambulance trusts in the local area. And I have a special interest in anything to do with ECGs and cardiology predominantly. Us as the company STC Training Solutions, we were originally set up as a first aid training provider, but we've kind of branched into pre-hospital care and CPD events for healthcare professionals. We are a QualSafe centre, and we do run the FREC range of courses for anyone in the audience that might be interested in that type of thing. Fabulous. So just gone 7 o'clock, so we'll flick on to the next page if everybody's ready in that case. So just a bit of a plug then. Obviously we are a business. The webinars are free and will remain so for as long as possible, but obviously we are looking to run some face-to-face paid courses in the near future. Obviously things are still a little bit up in the air with COVID, but it would appear that we're going to be able to run these courses. Well, we're awaiting an announcement from the Health and Safety Executive on running face-to-face courses, but it looks like in June we're going to be able to get back to something resembling normal on these. A few courses coming up. So we've got ILS for anyone that's interested. That's aimed predominantly at FREC 4s to keep their certificate up to date. It's an annual course. But it's also ideal for healthcare professionals that don't work in the emergency environment that would need to respond in an emergency. So people like myself in GP land, the course is ideal for them. We've got one of those running on the 13th of June. Safe administration of life-saving meds has proven to be very popular. Actually, we've nearly sold out the 20th of June, which is great news. But we will be looking to put extra dates on. And FREC 3, we've got a requalification course and an initial course coming up towards the end of June. All of these courses are in Aylesbury. Obviously, we're waiting for the decision to be made on face-to-face training. We'll be looking to reopen our Uxbridge centre fairly soon. And actually this year we'll be looking to open some more training centres across the country. If any of those interest you, then sales@stcsolutions.co.uk, and we can get you booked on. There will be more dates coming, and probably the more exciting of those is the FREC 4 we're looking at running on the 8th of August. More details to come. Manchester Training Centre, I did actually have that in mind, Matt. I don't think it's going to be, I don't know that we're going to make that this year. It'll all depend on how quickly we get back to normal, but yeah, that's something up north would be on the cards, definitely. So fantastic. So without further ado, we'll get that's the plug over and done with. So we'll get on with so tonight's webinar. So as the last ones, for those of you that haven't been along, we really want these to be interactive. So lots of chat going on. We've got the chat open. STC admin are there to answer any questions while I'm talking. So any technical problems or any questions you have as we go along, fire them into the chat. You can WhatsApp us as well. We've got that open, 07535 38223 if you don't want to put your question to everyone. Try not to use a private message, because actually we noticed last week the private messages get missed fairly easily, particularly if they're to me, because I don't see them until the end. So If you've got a private message, just send us on WhatsApp. You can also tweet us at STC Training Ltd, STC Training Limited, or email us. And of course, this is after the webinar as well, webinars at stctrainingsolutions.co.uk. If you have any questions or want to suggest future content, it would be great to hear from you. We use Mentimeter for some quizzes as we go through. So menti.com, grab your smartphone, pop the code in when the relevant slides come up, and you can answer live as we go along, which makes it a bit more interesting for everyone. If you, the more that participate, the better. It makes it more interesting. So last week we talked about blocks, and we talked briefly about Sgarbosa criteria. Unfortunately, it was a little bit rushed, so we've put Sgarbosa criteria back in for tonight. Actually, it's very relevant to acute coronary syndromes because that is the criteria. If you remember, those of you that did see last week's, they are the criteria we use to determine whether somebody's having an MI when they have underlying left bundle branch block. So that's very relevant. We'll have that in tonight. So tonight we're going to look at what is ACS, the pathophysiology behind it. Just a quick recap on the views of the heart and the ECG layout, and then we'll go into our STEMI criteria, which is the crux of what we're looking for really. When we request an ECG for our patients with chest pain, this is what we're looking for really, isn't it? So we want to make sure they are or aren't having an MI and react accordingly. So alternate lead views, so V4R and the posterior leads when they're appropriate to do those, and how we interpret those. As I say, we'll go over Sgarbosa's criteria again for those with left bundle branch block, and then we're going to talk briefly about management of ACS. Obviously, a lot of that is going to depend on your scope and your local guidelines, but it's just to give you a brief overview of predominantly for the ambulance folk out there of what we're expected to do for these patients. And of course, the Q&A session, as every week, will be at the end. You don't have to join in on that, and we'll let that run for as long as we're getting questions through. So anything you want, you can ask at the end. As I say, if you don't want to put it in the chat, WhatsApp us, numbers at the bottom right of your screen. But we do ask if you've got any questions as we go through, just put them straight in the chat. So when we come to a natural pause, I can answer those. So without further ado, let's refresh back to last week. So you're handed this ECG by the practice nurse. Somebody's come in for something routine, and they've done an ECG for whatever reason, and this is the end result. We'll assume that this patient isn't symptomatic at this moment in time, that it's just an incidental finding on ECG. But what is it? So I'm just going to flick over to Mentimeter just to activate the slide. So grab your smartphones, go to menti.com, 877825 is the code to put in. And we're going to answer what was this ECG showing. Okay, so bear with me. So that's the ECG. Have a good look at that. What's the ECG showing? It's an asymptomatic patient. For now, let's not overcomplicate it. What do we think's going on? Have a vote, lovely. I'll leave that screen up just so you've all got the code for a minute, 877825. Once you've got it loaded on your smartphone, you can vote. I'll flick backwards and forwards between the slide. Unfortunately, we haven't figured out a way of getting the ECG and the question up at the same time without them being too small to read. So we'll just make do with this. Great to see loads of you voting. Thank you. What's this ECG showing? Thank you. Yeah, that's a good idea. We'll put the code in the chat. Lovely, good. So some of you voting there. Let's just have a look at this. That's where we're going so far. 33%, 30%, 36%. Blimey, it keeps changing. Okay, so a good chunk of you thinking right bundle branch block, some of you thinking anterior MI, most of you thinking left bundle branch block, and some of you thinking left anterior fascicular block. Nobody thinking trifascicular block tonight. Vast majority of you are, of course, right. Left bundle branch block, so characterized by, if I can go back, characterized by these deep S waves in the anterior leads and these tall wide R waves in the lateral leads. Quite often notched. These ones aren't too much, but you can see in the lateral leads there's a little bit of a notch there. And of course, we get this discordance, which is the ST segments and the T waves going in the opposite direction of the S waves, or the Curie compluxes. And that's what gives us this kind of MI mimic. And we're going to talk about that a little bit later in Sgarbosa. But well done to the 47% of you that remember that from last week. So well done. Bit of pathophysiology then. So remember this from the first week, blood supply to the heart. So the blood vessels that supply the heart are protected from they sit behind the aortic valve. So as the valve opens, the pressures are slightly reduced within the cardiac circulation. Just so obviously you can imagine 120 or 130 millimeters of mercury coming out of the aortic arch and shooting straight down these tiny little coronary arteries would be destructive towards them. So the blood flow, the blood pressures within the coronary arteries is a lot lower. So we have two coronary arteries that come off the aortic arch, the left and right quite clearly. The left one bifurcates more than the right does, and the left bifurcates into the circumflex and the LAD, left anterior descending, who is also the diagonal branch a little bit further down. The right coronary artery is a little bit more straightforward, just wraps around towards the posterior of the heart there. So just a visualization of where the blood supplies are. And that, as we kind of talk through MIs and things like that tonight, as you see groups of changes within the leads, you can then start to visualize where the problem is and where the culprit lesion is likely to be. So we'll talk about that as we go through. So pathophysiology, just kind of back to basics, really. A normal artery there on the left. What generally happens as we get a bit older and we don't necessarily eat the right things, we build up some fatty deposit, lipid deposits, and dead white cells, things like that, along the endothelial walls of the tunica intima of our blood vessels. So we're talking specifically within the coronary arteries now in this type of lecture, but this does go on, of course, all over the body and gives us peripheral artery disease and so on and so forth. But when we're talking specifically about the heart, so fatty deposits build up. They cause changes within the cells themselves of the tunica intima and the tunica media, the two kind of layers of the blood vessel. And that starts to form this third diagram on the right hand side there of the stable plaque. So eventually the cells of the tunica intima, the most internal layer of the blood vessel, starts to grow over and affect this fatty plaque layer. So it's nice and smooth as possible and allows the lumen to open slightly so that the blood flow isn't cut off too much. That's kind of the body's natural defense mechanism. But every now and again, unfortunately, what can happen is that these plaques, which are of course known as atherosclerosis, that build up of fatty material within the arteries is atherosclerosis, and the plaque itself is the whole kind of product that it forms. If those plaques rupture, some of this white material within the plaque can leak out and become into contact with the blood flow that's passing by. And they're very kind of prothrombic, so any kind of contact with the clotting factors within the blood is going to cause the formation of a thrombus. Okay, and that's this end stage here, which is unstable plaque formation, and this is what leads to our acute coronary syndromes, is effectively a large blood clot forming over these plaque ruptures, and that can happen, very, very quickly over the space of hours, actually. And it's different variations of these that give us our acute coronary syndrome. So in very basic terms, an unstable plaque formation that doesn't occlude the entire lumen of the blood vessel is going to give us unstable angina and non-ST elevation MIs. And complete occlusion is most likely going to give us full-blown STEMI, ST elevation MIs. Hopefully that makes sense. Just a nice little brief. I think everybody's taught this at some stage in their first aid training / ambulance training or medical school. It comes up at a very early stage, generally the kind of anginas and MIs, but it's good just to refresh our minds. So some definitions as we go forward. So stable and unstable angina, not always that obvious, but stable angina, it's a really simple definition really. Stable angina is predictable chest pain. So it's symptoms that only come on exertion when cardiac output is increased. So you can have, say, plus minus ST depression and T-wave inversion. Sometimes they're not always. We'll talk about ST elevation and ST depression, but ST depression generally is associated with ischemia, and ST elevation is associated with infarct. We talked in the last slide, stable angina is well, all the anginas is effectively a partial occlusion of the blood vessels, and so far the cardiac tissue down route of that is becoming ischemic. So in some cases you'll see ST depression and T wave inversion. Doesn't mean to say you'll see it every time, but that's stable angina. It's diagnosed clinically for those that are interested, and predominantly with a stress ECG. So if you put somebody on a treadmill with their ECGs attached, if they get chest pain and more than 1 mil of ST depression in any lead, then that's diagnostic of stable angina, provided their symptoms settle on rest again. The main difference with unstable angina is it's unpredictable. In effect, it comes on at rest. It comes on doing something that wouldn't normally provoke that patient to have angina. And of course, these patients may have stable angina ongoing that hasn't been diagnosed at any point. But as I say, the key is random onset at rest, sudden onsets, that type of thing. Whereas stable angina is the gradual onset, and it's got some kind of precursor to it, as in generally increased cardiac output, if that makes sense. So to tell the difference between the 3 coronary syndromes, which of course are unstable angina is one of them. So non-ST elevation MIs, the NSTEMIs, and ST elevation MIs, the STEMIs. You're looking for what the ST segments are doing, and you're looking at your biomarkers, and predominantly we're looking at troponin in that case. So if troponin's normal, there's no ST elevation, we're looking at unstable angina. Troponin rises when myocardial tissue starts to die. So you actually need the infarct. Infarct is cell death. So you need that infarct to actually to get abnormal biomarkers. So the definition then of NSTEMI and STEMI is they both have abnormal biomarkers because you have cell death, you have myocardial cell death. In NSTEMI, you don't have ST elevation, as the name suggests. In STEMI, you do have ST elevation. Hopefully that's a nice, simple kind of clarification of what's going on there. So. And a quick refresher of lead views, and then I think it does come up a little bit later, just overlaid on the heart itself. So your limb leads, so looking at the bottom wall of the heart, so basically we have views of the inferior wall of the heart, the bottom of the heart, we have a view of the front wall of the heart, the anterior, and we have a good view of the lateral wall, the left lateral wall of the heart, which is obviously the lateral view. Leads 2, AVF, and lead 3 quite clearly look up at the bottom of the heart, so there are inferior leads. Leads AVL 1, V5, and V6 look quite well at the lateral side, so of course they're the lateral leads, and the remaining leads V1, 2, 3, and 4 are looking at the front wall, the anterior wall of the heart. And if you may remember from last week or the week before, V1 and V2 are commonly called the septal leads because they actually look at the septum of the ventricular septum. And again, there's just another diagram here which explains the chest leads in a little bit. You can see V1 and V2 are looking quite well at the septal wall there. So again, when the ECG prints out, your inferior leads print out at this bottom L shape here. The anterior leads, of which the septals are included, these 4 leads here form this kind of R shape. AVR is the odd one out, so the lateral leads are the 4 remaining ones looking at the side of the heart. Hopefully that's all clear to everyone. That's been covered before. And of course, the relevance of this is when we're seeing groups of leads that are having kind of changes in them, we can start to look at which part of the heart is affected. So why do we never hear septal elevation? We do. It's just kind of masqueraded under anterior, and we do come on to that, Stuart, in a little while. Different classifications of anterior MI, of which a septal wall MI is one. But it's rare, and actually the ECG isn't that specific in picking that up. So we'll talk about that in a bit more detail. Too impatient? No, it's absolutely fine. It's all relevant. So we're going to talk about reciprocal changes a bit later tonight, and I just want to be certain that everybody's clear on what a reciprocal change is. So for each action, there's an equal and opposite reaction. And there's no difference in electrophysiology. So when you see ST elevation in one lead, you will see ST depression in its reciprocal lead. And this really handy table I found kind of summarizes, so we can't always get reciprocal views of different leads, but this summarizes quite well which leads have reciprocal views. So for example, your inferior leads 2, 3 and AVF, if you were to just kind of double check your diagnosis, you wanted to look at a lead that's looking in an opposite direction, your high laterals, 1 and AVL, are going to be looking from the opposite direction. So if you get ST elevation in your inferior leads, you should be getting ST depression or some kind of reciprocal change in your high laterals. And vice versa, if you look in your lateral leads, if you're getting ST elevation in your laterals, you should be getting some form of ST depression or reciprocal change in your inferiors. We will see a good example of that later. But effectively, reciprocal change is just if you have ST elevation in one part, you'll have ST depression in the opposite view. So, fantastic. So, case study then. So this is, we're going to follow this patient through this evening. So tonight you've got a 999 call, 57-year-old male chest pain. We'll make it a 999 call because we all know if it was 111, it wouldn't be a genuine chest pain, would it? So history of presenting complaint tonight then, sudden onset after dinner 30 minutes ago of this chest pain. You can assume it's very classic cardiac, central, crushing, the usual stuff. Feels like he's going to faint. He's vomited 3 times. When you get there, he's poorly perfused. He's diaphoretic, sweating lots, and he's obviously quite anxious. Impending doom is the phrase they use, isn't it? So past medical history certainly puts him at high risk there of cardiac risk factors, doesn't it? So I like high BMI. This up arrow and BMI must be my most favoured kind of little clerking tool. It's a nice way of saying the patient's fat, isn't it? So maybe call for another crew for a difficult extrication and you don't want to say it. So high BMI. Take some obs. Quite clearly, we're looking at this patient. He's not looking very well to us. We do some obs and they confirm that he's not very well. Slightly tachypnic. His sats aren't reading. He's a little bit bradycardic, hypotensive, definitely. Temperature and BM, if you've bothered to do them, you notice the BM's up a little bit, and he's slightly confused at GCS 14. Well, hey, no surprises there then. You can kind of almost diagnose this patient before you put the leads on, can't you? For those of you that have seen MIs, they generally do look, they certainly have a certain look about them. So what do we think is going on here, folks? There is a Mentimeter coming up, so don't pop it in the chat. Have a think to yourself, have a look at this ECG with the history there. So we've got a chest pain with some cardiogenic shock features coming into it. This is not a very well patient with sudden onset chest pain, and we've got this ECG. Have a little think in your mind what we're going to call this diagnosis. I'll just bring the Mentimeter up so it's alive. 877825 again, the code is in the chat. So I'll flick back to the ECG, let people have a look. So it's a sudden onset chest pain in a 50-something-year-old male with lots of cardiac risk factors, and he looks unwell. His observations are terrible. We are worried about this chap. So let's get plenty of you voting to make it as interactive as possible. Start to have a think. So we're going left bundle branch block, inferior STEMI, anterior STEMI, lateral STEMI, or unstable angina. What are we thinking? Let's get a few more of you voting. I'll flick back to the ECG again. What are we seeing there? Lovely. Good. So lots of you going for inferior STEMI, some of you going for lateral STEMI, more of you going for inferior STEMI now. It's a bit of the herd effect going on. Lovely, you are of course right. Inferior STEMI, let's talk about why. So ST elevation MI, so we've got the history suggesting a cardiac episode going on. We can't test the biomarkers at the moment on the roadside, so we have to just go by history. This is likely an acute coronary syndrome. What makes this a STEMI is we have ST elevation. Have a look at your inferior leads 2, 3, and AVF. What are we seeing there? ST elevation is measured from the point where the S wave becomes a T wave, don't forget. It's known as the J point, and as you can see, it's quite clearly raised from the isoelectric line, which is from your T to your P, basically. So you can see in leads 2, leads 3, and AVF, they are raised. So that's ST elevation in the inferior leads. So it's an inferior STEMI. Well done to most of you, you got that right. So the lateral leads, some people are saying there was a lateral MI going on there. Just have a little look at what the lateral leads are doing. There's no ST elevation there. There's a bit of ST depression there, but nothing there, nothing there. This ST depression here, what are we going to call it? Throw it in the chat. What do we call this? So we've got ST depression in AVL when we've got reciprocal change. Fantastic. Well done. Yeah, lovely. Well done, guys. You're getting it. So this is the first example we'll see tonight of reciprocal change. It's just a bit of an extra nail in the coffin, if you like. Maybe that's the wrong analogy, but it's because these patients aren't well. But it's another way of just confirming our diagnosis. So well done. So locating a culprit lesion then. So we've just said that this chap is having an inferior MI, but sometimes it's nice just to have a think about which blood vessel is being affected and whether that's going to cause us any other problems. Okay, so blood vessels from the first slide. So left coronary artery heading down the front, left circumflex heading around the side, right coronary heading to the bottom and to the back effectively. So no surprises then. The left anterior descending innervates, that's the wrong word, isn't it? Perfuses the front wall, the anterior wall of the heart. The circumflex innervates the lateral wall, and the right coronary artery innervates the inferior and posterior walls. That's the majority of cases. There are, and if you want to do any more reading around this, there are some fairly good instances where that doesn't occur, but it tends to be in certain ethnic groups with poorer collateral circulation, things like that. But it's good to have a read around. But in the majority of people, that's how the blood flow works within the heart. And obviously we can have a look then. So your inferior leads 2 AVF and 3 here are going to be looking at the inferior wall of the heart. The inferior wall of the heart is perfused by the right coronary artery in most adults. So if you see a group of problems in the inferior leads, we're thinking right coronary artery is at fault. We also have a good view of the anterior wall of the heart through V1 to V4 if you've got anterior problems. And this is the nice easy one because it's called the left anterior descending. It's probably going to be the LAD that's at fault. And of course, last but not least, if you see lateral wall changes, we're probably going to be blaming the circumflex. Okay. Just out of interest, if you see changes in the anterior walls and in the lateral walls, on that basis, where do you think the culprit lesion is going to be? Pop in the chat very quickly. So we've got changes to anterior walls, so the LAD is probably included. So the diagonal branch mat is probably going to give you more lateral ST elevation if you think about that, because it's more the lateral side. So left coronary artery, hey, wonderful, yeah. So if we're seeing changes to both the anterior wall and the lateral walls, we're thinking that this block is quite high up. So the left coronary artery, and it's also known as the left main stem. Personal setup iPad, a few, well done. Absolutely, yeah, you're right. So if we've got a blockage of the entire left coronary artery, it's known as a left main stem occlusion, LMS occlusion. These patients aren't very well. Okay, they don't tolerate having anterior and lateral infarct for very long, as you can imagine. So just a quick talk. Obviously, we're assuming most people have come across these terms before. Just to be clear on what we mean. ST depression is where your we're talking about these ST points, also known as the J points, are where your S wave becomes a T wave. You can find those on most ECGs fairly easily. There's always a little bit of debate when it's marginal, but generally you can find fairly easily where that point is. ST depression is where that point sits below the isoelectric line. ST elevation is where that point sits above the isoelectric line. Nice and easy. We further categorize ST segments by whether they're upsloping, downsloping, or horizontal. Horizontal is generally the worst kind because it's generally reciprocal change for ST elevation somewhere else, and we'll show you a really good example of that later. So horizontal ST depression is a bad sign. You definitely don't want to be leaving those patients at home if that's what the decision's all about. So wonderful. So I just want to cover a subject or a phenomenon called high takeoff, or more correctly known as benign early repolarization, BER. It does get debated amongst, I've certainly heard paramedics talking about it on the road, where we're trying to figure out whether someone has ST elevation or high takeoff. Now, the very simple answer to this question is if you have a patient with chest pain and you're trying to figure out whether they've got ST elevation or high takeoff, you need to stop having that conversation and go somewhere where they can have a definitive diagnosis of what's going on. Don't be the one that says this is high takeoff when it's a massive anterior MI. That's my take-home message from this slide. But if you want to know a little bit more about BER, benign early repolarization, high takeoff, it commonly occurs in younger, healthy adults. And I'm pretty sure I read somewhere along the line of researching this that it was more prevalent in Black Afro-Caribbean men, young, healthy Black Afro-Caribbean men, but it can occur in any young male. I've certainly seen it in white English males as well. So it becomes more and more uncommon as you get older. It's actually very uncommon in everyone over 50. If you're actually having the conversation with somebody about whether an over 50-year-old is having ST elevation or high takeoff, you need to have a word with yourself, because over 50 is most definitely going to be you're going to be treating that as an ischemic change. In the over 70s, it's almost rare. No, so it's not a PVC. We will come on to what it actually looks like on the next slide. In fact, I'll just flick to it. Benign early repolarization is effectively an ST elevation mimic. So it mimics, it can mimic MI, it can mimic pericarditis. So some of the kind of giveaways that it is early repolarization rather than ST elevation, genuinely associated with infarct, is it's a young, otherwise well patient generally. They generally tend to be slim as well. So of course, by definition, at reduced risk of cardiac problems. It generally occurs in multiple leads, whereas infarct generally, unless it's a nasty infarct and you've caught it before they arrest, generally you don't see elevation in multiple groups of leads. This is a really good example of BER here. So you've got anterior elevation, we've got some lateral elevation, we've got some inferior elevation. That just doesn't happen in infarct. So you're thinking BER or pericarditis. In the absence of a fever or pleuristic sounding chest pain or anything else, any other infection markers, you're pretty much left with BER at that point. But the actual diagnostic criteria are widespread concave ST elevation, so ST elevation that's concave. I seem to remember when I was first taught about this phenomenon, if you draw two eyes up here, you'll get smiley face. That means concave ST elevation. So generally, if it's a smiley face, it's not going to kill you, but of course, there are some examples of that not being so true. You can sometimes get a notched or slurred J point. I don't know if we have any examples. I mean, there you go. So the J point in V5 there is notched and slightly slurred. By slurred, we mean kind of scoopy shape. What's happening in AVL? Not a lot. It's the isoelectric lead. If you remember back to last week, John, about looking for cardiac access, AVL is pretty much it's pretty much your most isoelectric least voltage. But basically, it's a negative QRS with a bit of a notch on the end, but you can't really interpret much about what's going on there, but a good spot. So prominent asymmetric concordant T waves, and so concordant T waves basically meaning they're going in the same general direction as the QRS complexes. Leads V2 and V3, they're not quite doing that, but in this case, this is benign early repolarization. So again, these rules are mostly there, but like everything in medicine, there are the odd patients that don't have it. But effectively, you're looking at widespread ST elevation in a patient that you wouldn't expect to be having infarct. In everybody else, you're going to treat these as acute coronary syndromes. You're going to take them to hospital for further tests. I would suggest that you're probably going to have a conversation with cardiology before you activate the cath lab in somebody like this, because we know from evidence that ST elevation doesn't present itself in this many leads when somebody's having an MI, for the very reasons that we just talked about of reciprocal chains. If you imagine if you were having a lateral wall MI in this case, you'd expect to see some ST depression in most other leads. So the fact that everything is elevated strongly suggests that this is something other than an MI, but that's just in there. As I say, don't think too much about it. If you see someone with ST elevation and chest pain, you're going to treat them for that. If you're really thinking that this isn't an MI, you're thinking that this might be benign early repolarization, then the rules for diagnosing it are there. But it's a brave decision, and you have to be certain you've got it right. And of course, you don't want to miss pericarditis either. So just be thinking along those lines too. So we'll crack on with the true ACSs, so STEMI criteria. So these may, just as a bit of a caveat on these may vary between trusts, particularly in the NHS, but although these are pretty standard from what I've seen everywhere I've worked, these are the rules we go by. So in inferior and lateral leads, we're looking for more than 1 mil of ST elevation. So 1 mil is one small square. And in the anterior leads are slightly different, and of course we include the septal leads in this. So men, you need more than 2 mil of ST elevation, and in women, you need more than 1.5 mil of ST elevation. So in all cases, you need 2 consecutive leads. So if you just had isolated ST elevation in lead 3 and nowhere else, that wouldn't be diagnostic of of a STEMI, so you might still be considering one of the other acute coronary syndromes, but you wouldn't be thinking that's an ST elevation MI at that point, unless one of the other inferior leads popped up as well. So likewise, if you had isolated ST elevation in lead V2, which isn't that uncommon to see in a normal healthy heart, you wouldn't activate the cath lab. You would wait to see ST elevation in another lead, or you would just treat it as another form of acute coronary syndrome. Hopefully that makes sense to everybody and come across those rules before. So 1 mil in everything except the anterior leads, where we're looking for 2 mil in a man and 1.5 mil in a woman to be diagnostic, and 2 consecutive leads in each group. Okay, so here we go. Nice example of an inferior MI, just to put that into context here. So we can see nice clear ST elevation in the 3 inferior leads. We've got some reciprocal change in AVL. This is a really good example of an inferior STEMI. Hopefully everybody's fairly happy with that. So what makes it inferior STEMI is going to be the history in our case, unless you can measure troponins biomarkers. For most ambulance crew that are out there, or those that are working in other kind of pre-hospital environments, you're not going to be able to measure those. So you're looking at history plus ST elevation. Treat the patient, not the numbers. So if you've got a patient that's sitting there in front of you that looks absolutely fine, I doubt they would be with an ECG like this, but if you do see some kind of mild elevation and your patient looks fine, I can fairly confidently say it's not an MI, but it probably does need some investigation just to make sure we're not missing something. But if you have a well patient, they're not dying. Yes, point of care testing for CHOPS. So it's being trialled now. I can't remember which ambulance service, but there are some critical care paramedics out and about that are testing roadside CHOPS. I believe London were supposed to be doing it, but I think it's gone on hold. I haven't heard any more about it, so it would be good to get on with that. Fab, yes, they are. Yeah, it is ongoing, so that'll be really good. So next quiz, get your phones again. So inferior MI, which vessel are we is being affected? So we've got ST elevation in leads 2, 3, and AVF. Which vessel is affected? Where is the lesion? Have a vote. See if we can get half of you voting. The more that you vote, the better it is, and the more you learn as well. Lovely, well done, folks. Any questions in the chats? No, lovely. Fantastic, well done, guys. Let's see where we're all at. So most of you saying the right coronary artery, some of you saying the left main stem, some saying circumflex, some saying LAD, some saying diagonal branch. Okay. Right, so right coronary artery, most of you getting that right. So remember, the right coronary artery perfuses the inferior wall and the posterior wall. Your left main stem is associated with widespread anterior and anterior septal, anterior lateral MIs, should I say. So left main stem, you'd expect some anterior changes and some lateral changes. Circumflex, you'd just expect to see some lateral changes. Your LAD would just be anterior changes. Your diagonal would be some lateral changes. Okay. Oops. Lovely. So nice anterior STEMI example here. So whereas last time we had the elevation in these 3 leads, we've now got elevation throughout the anterior leads. Remembering saying V1 to V4 are generally classed as your anteriors, V5 and V6 are your laterals. V1 and V2 do look at the septal wall, so we're going to talk about that in a bit more detail in just a minute. So in this case, we have septal wall involvement, we have anterior wall elevation. We do actually have a little bit of lateral wall. It's very rare that you get just anterior MIs on their own. Generally, there's always a bit of lateral wall involvement. That's just because of the way the blood vessels go and the diagonal branch being connected to the left anterior descending. If the diagonal branch goes, if it's a high kind of proximal occlusion of the LAD, you're going to get some lateral wall infarct as well. So in this case, it's an anterior STEMI, so I'm not going to help you this time. What's the most likely vessel? In this case, I say I'm not going to help you, I just did, but Lovely. So Ash, should we have a vote on the Mentimeter if you get the chance? Lovely. I'll wait for half of you again. Fantastic. That's it. More of you the vote, the better it is for everyone. Fantastic. Most of you going for the LAD. Lovely. Well done, everyone. So again, we talked about right coronary is inferior and posterior. Left main stem, you'd expect to see anterior and some lateral changes. So I see where you're going with these guys. There were some lateral changes occurring here, but not in every, well, arguably there is a little bit in these lateral leads. So do you know what, the 24% that said left main stem, there's a good argument there actually. The anterior and the lateral wall are being affected. The correct answer in this case, and actually this ECG was diagnostic of an LAD occlusion, but it was a proximal LAD occlusion, and the diagonal branch had therefore been knocked out. So your diagonal branch innervates some of the lateral wall. So this lateral wall change would just come about from the diagonal branch being knocked out, but this was a proximal LAD occlusion. Was the actual, sorry, I mean, technical problems again, there we go. So it was a proximal LAD occlusion on this actual ECG. But yes, I can see why you're thinking LMS, and you could certainly have that as a differential. Looking at that ECG, the diagonal branch wouldn't necessarily, well, wouldn't give you any anterior changes. It would just give you lateral changes, generally the high laterals. So lead 1 and AVL. Okay, perfect. So we'll go to the next slide. So we talked about this different, you know, we classify anterior STEMIs in slightly different ways. I think somebody asked about that earlier. So the septal wall. So an anterior MI, technically, when you say to somebody that they're having an anterior MI, it's you're diagnosing that through ECG evidence of ST elevation in V2 to V5. A septal wall MI would be isolated to V1 and V2. An anterior septal would be V1 to V4. That makes sense, doesn't it? The anterior wall and some of the anterior wall. An anterior lateral would be V3 to V6 plus some of the lateral leads. So the ECG we just looked at was actually kind of a true anterior, because the predominant ST elevation was V2 to V5. If you remember, well, it's actually up here, isn't it? So V2 to V5 are where you're seeing the biggest ST elevation. So this is a true anterior STEMI. If that elevation was isolated to V1 and V2, it would be called a septal wall STEMI. If it was V1 to V4 were the biggest, you'd have an anterior septal. If you were looking at V2 all the way through, so technically you could argue that there's more than 1 mil of elevation in these leads, in which case you could call this an anterior lateral. And then extensive anterior and anterior lateral MIs are when you get left main stem occlusion, and you would expect ST elevation in all of the anterior and all of the lateral leads. And actually, this ECG isn't far off that. Hopefully, that's making sense to everybody. They're the kind of classifications of anterior STEMI. When you say anterior STEMI and mean anterior STEMI, you're actually talking about V2 to V5. But just bearing in mind that there are some differences if you want to be pernickety with it. And cardiologists love to be pernickety, I've noticed. So you'll really impress them if you're going with that. So. Lovely. So this, so we'll talk about lateral STEMIs. It's really quite rare to get lateral STEMIs in complete isolation. You generally get some anterior wall involvement as well, as we've kind of seen beforehand. So, but this was an example I found of a lateral wall STEMI. So V5 is, maybe I've confused you, Ash, there. So V5 is circumflex, you're absolutely right. But when we talk about the true definition of an anterior MI is ST elevation from V2 to V5. V5 looks at kind of the point at which the heart stops becoming the anterior side of the heart and becomes the lateral wall, if that makes sense. So V5 is kind of in between anterior and lateral. It's considered for all intents and purposes to be a lateral lead, but that gets confusing then when you consider a true anterior MI would have elevation in V5. If it stopped at V4, it would be an anterior septal MI in definitions, but we're being very pernickety there If you see elevation in V5, have a look around it. If there's elevation elsewhere, it doesn't really matter whether we're calling it lateral, anterior septal at that point. That patient's having an MI. So hopefully that clarifies it for you. No problem. So a lateral wall STEMI. So so a lateral STEMI, we are looking for ST elevation in any two leads of 1 AVL, V5 and V6. So in this case, there's a little bit of elevation in V5, there's a little bit less elevation in V6, but there's absolutely stonking loads of elevation in 1 and AVL. So this is diagnostic of a nice lateral wall STEMI. As I say, it's very rare to get them on their own. So what else is going on in this ECG, folks? We've got loads of really good examples of, remember when we talked earlier, every lead has a reciprocal lead. Yeah, very narrow QRSs. That just means that there's no electrical block. It's still conducting nicely down through the Purkinje system. But there's lots of reciprocal change going on here, folks, isn't there? So you've got where you see a lateral MI, you're generally going to see lots and lots of ST depression going around all over the place. So reciprocal change, lovely. AVR and AVF ST depression. Yeah, so AVR not so much ST depression, and the normal. It's normal to have an inverted T wave. AVF definitely some ST depression. So yeah, lots of really good examples of reciprocal change here. So the lateral wall is elevated, the inferior wall and some of the anterior wall is depressed. That is just reciprocal change. It just points to the fact that this patient is not very well. So lead V4. So no, there's no elevation there in lead V4. We have a a hyperacute T wave. The T wave is bigger than it should be, but no, that doesn't look elevated to me there. I'd say the J point is about isoelectric. So I'm only seeing elevation in V5, slightly in V6, massively in 1, massively in AVL. That's slightly depressed, massively depressed, massively depressed, and then your anterior leads massively depressed through those three. That one looks isoelectric to me. Just about. So, which vessel, cast your minds back, which vessel is most likely affected in a lateral, an isolated lateral? You can get lateral changes in other vessels, but when you just see the lateral leads off like that, which culprit vessel do we think? Lovely. So most of you saying circumflex, that's good. I think the message is going home, so that's good. So yeah, absolutely right coronary, inferior, posterior, left main stem would give you anterior and lateral. Circumflex will give you isolated lateral. LAD will give you isolated anterior with sometimes a little bit of lateral. Diagonal branch will give you a little bit of lateral and some anterior. Left bundle branch block in that last ECG, so we can go through the diagnostic criteria. So left bundle branch block, your diagnostic criteria are deep S waves within leads V1 to V2, quite often notched, quite often more than 120 milliseconds, and tall R waves, again slightly notched. So we can certainly see in the lateral leads, so your tall R waves in the lateral leads, we can certainly see that's the case in lead V1 and V2. They're both notched. Not quite wide enough to be a left bundle branch block, but it could be an incomplete, couldn't it? And we've got deep S waves. Potentially there's some left bundle branch block going on here. The thing that puts me off that is there's only kind of very slight left axis deviation. But you're absolutely right to think about left bundle branch block. There is an element of that in here. But it's the underlying what's going on here is a lateral wall MI, and what you're seeing is reciprocal changes. The QRS isn't quite wide enough to be left bundle in that case. If that makes sense. Okay, so we don't have a view of the posterior of the heart, do we? So we can see the anterior wall of the heart, we can see the inferior wall, and we can see the lateral wall, but we can't actually directly visualize the posterior wall. And I talked about ST depression that's flat a little bit earlier. ST depression when it's flat is almost always reciprocal change. So if we have reciprocal change in the anterior leads, where do you think the elevation is going to be? in the posterior leads, isn't it? So there is a bit of a cheat here. So if you want to kind of diagnose a posterior MI without sticking the posterior leads on, so in leads V1 to V3, we're only looking at these 3 leads here. Horizontal ST depression with positive T waves and tall R waves. Do we have those 3 things? Absolutely. So there's your horizontal ST depression. We have positive T waves. We have tall R waves, all in V1 to V3. Actually, so tall R waves, I prefer the term good R wave progression. So you can see the R waves growing nicely through the right precordials. That to me diagnoses a posterior MI. But that brings us nicely into alternate views, doesn't it? So we'll start with suspected posterior STEMI. If you're not sure and you want to diagnose, pop 7, 8, and 9, V7, 8, and 9. So you just take off V4, V5, V6 from the front of the patient, pop some new dots on and stick them on the posterior aspect. So underneath the left scapula, V8 just at the tip of the scapula, V7 and V9 kind of a couple of centimeters either side of that. And have a look at the posterior wall of the heart directly. That's the easiest way to diagnose a posterior STEMI. If you have these types of symptoms here and you have a patient that looks like they're having an MI, that for all intents and purposes is a posterior MI. But if you need to prove it for whatever reason, that's how you do it. The other kind of alternate views, and hopefully some of you have heard of V4R. So when you diagnose an inferior STEMI, it's best practice. We probably don't do it often enough. But it's best practice to have a look to see whether the right ventricle is involved, whether you have a right ventricular infarction. And that's relevant because those patients are much more unstable and react a lot worse to the drugs that we're going to give. We'll talk about those in a little while. So with normal views, your diagnostic criteria were more than 1 mil in 2 consecutive leads in either the inferior or the lateral walls, more than 2 mil in the anterior walls for a male, more than 1.5 mil in the anterior wall for a female, again in 2 consecutive leads. When we look to the alternate views, that changes slightly. So you only need more than half a mil of elevation in any 1 lead. So obviously you've only got 1 lead in the V4R. You've got 3 leads in the posterior view. So any of those leads is more than half a mil elevated. You are going to see that's a posterior wall MI. And the artery posterior is the right coronary in most people, Ash. So that's a right coronary occlusion, but it's going to be quite a distal one. If you imagine a proximal occlusion of the right coronary artery is going to knock out the inferior wall as well, isn't it? So, excellent. So this is an example of V7, 8, and 9. So when you do these, remember that the ECG is still going to print them out as V4, V5, V6, so you don't get confused later down the line. Cross it out and write 7, 8, 9. Just so you know that you were looking at the posterior angle of the heart. So this was the same patient. So you can see in leads V1 to V3, we have the diagnostic criteria of posterior MI. We've done a posterior trace and bam, we've got the diagnostic. There's more than half a mil of elevation quite clearly in all 3 of those leads. So we know that this patient is having a posterior STEMI. And Ash is going to ace this question. Awkward to list on digital uploads on EPR, is it? There you go. I'm new to SCAS, so fair enough. Let's get voting on there. Definitely the carotid. Oops. Oh my goodness, doesn't want to work. There we go. Let's see who's doing what. Oh, I've given you the answer now. So well done, right coronary. Lovely. So the right coronary artery, don't forget, it starts off, it branches down, it innervates the inferior wall, and then to be most correct about it, it's the right posterior descending branch of the right coronary artery that innervates the posterior wall, but it is just a continuation of the right coronary artery. So it's a distal, if you have an isolated posterior MI, you're going to have a distal RCA lesion, and as I say, more correctly termed the right posterior descending artery after it innervates, perfuses the inferior wall. So, fab. So we talked about V4R being relevant. So this is an example of a V4R. So you can see that there's an inferior wall STEMI going on, quite a nice one there. So certainly wouldn't want that as my ECG, but it'd be an interesting patient to treat, wouldn't it? So they've done a V4R and that's positive, that's elevated. It means the right ventricle has been potentially knocked out as well. Basically, all that means, if you imagine the pump was kind of working from one side. If you knock out the right side as well, you've completely knackered the pump. So you've just got to be very careful with what you do with drugs. So they're likely to be hemodynamically unstable. And actually, on this point, the right coronary artery, and actually it was really relevant to the patient that was our case study at the beginning. Do you remember? So he was slightly bradycardic. The right coronary artery supplies the SA node, and the SA node, if it becomes hypoxic, slows down. Okay, so it's just something to bear in mind. So if you knock out the right coronary artery, particularly a fairly proximal lesion, you might find that you get bradycardia, and that's because the SA node is being kicked out. So these patients are likely to be hemodynamically unstable for those two reasons. One, because the pump's knackered, and two, because the pump is slowing itself down. Careful use of GTN for that reason, and careful use of fluids. The main reason we're careful with fluids is we don't want to pump them full of, giving them acute pulmonary edema, just to make their story worse. So does the inferior STEMI progress to cardiac arrest more often? Inferior STEMIs tend to be the more unstable of the two. But no, as far as I'm aware, no one or other is more or less associated with cardiac arrest. Although a bit of an arse about face way, the anterior wall STEMIs are more associated with morbidity. So those that have big anterior STEMIs generally die. Higher percentage of them die, but I'm not aware of an inferior or an anterior being more associated with cardiac arrest as such. Ash, they're all at high risk. So that's all something you're going to want to expect rather than kind of prepare, rather than kind of react to. So when you diagnose an MI, you're going to have in the back of your mind, if you're lead clinician anyway, that this patient is going to arrest, and then you're kind of already in the right mindset for when it happens. But these patients are unstable. But the reason that the right coronary artery tends to make them even more unstable is because both ventricles get affected, and quite often the SA node gets knocked out as well. That's why. So back to our friend Sgarbosa from last week then. So just to refresh on that, and it's obviously really relevant now, isn't it? So in patients that have left bundle branch block, and here's a good example of left bundle branch block. As I say, it was long talk to us that we couldn't decipher whether or not there was an MI going on. So this is a nice clear left bundle branch block, which is Sgarbosa negative. And we'll work through the criteria. So there's 3 criteria set by Sgarbosa. One, which said that so remember what we said with discordance and concordance, because that generally confuses everyone, the terminology around it. Discordance is where the ST and the T wave are going in the opposite direction of the preceding QRS complex. So this is a normal left bundle branch block, ECG. So every lead where you have a predominantly negative QRS complex, you should see ST elevation and a positive T wave. Okay, so we can check that through. Pretty much, it all looks good, doesn't it? So predominantly negative, predominantly positive. So that's discordance. That's appropriate. That's what left bundle branch block does. Okay, and then you have discordance the other way around. So in leads where there's predominantly a positive, so you're looking at your laterals. Where there's leads with a predominantly positive QRS, we should see ST depression and some form of T wave inversion, which in your high laterals is nice and clear there. Okay. So what Sgarbosa said was that if in any lead where the QRS complex was positive, if you had ST elevation, that's abnormal. And if that patient looks like they're having an MI, they're having an MI, okay? So looking at your high laterals would be the best examples here. If you were to see ST elevation in either of these leads, in a patient that fits the criteria of an MI, that looks like they're having an MI, then that would be Sgarbosa positive on criteria A, okay? And remember, that got you 5 points. So you only need 3 or more to go to the cath lab using the standard Sgarbosa criteria. Again, a little bit trust specific because some trusts don't use it. But if you see ST elevation in lead 1 or AVL on this patient, you're going to go to the cath lab. So the next rule Sgarbosa said was in the right precordial, so V1 to V3, if you were to see any ST depression, that would be abnormal and that would score you 3 points. And again, we know that 3 or more takes you to the cath lab. So if we see ST depression in any lead, V1, V2 or V3, that's abnormal. If the patient looks like they're having an MI, off they go to the cath lab. All right. Now, the contentious issue was always Sgarbosa C, and I'll just flick back. So Sgarbosa C was that in any lead where there was a predominantly negative QRS, where you would expect to be seeing ST elevation and a positive T wave, so discordance. If that discordance was inappropriate or excessive, and what Sgarbosa originally said was excessive, was more than 5 mil. So if you saw more than 5 mil of ST elevation in any lead where the QRS complex was negative, and that's predominantly your anterior leads, then you are going to treat that as an MI. But actually, in testing, in trials, that didn't come out as very specific. So what a chap named Smith came along and modified C. So it's called modified C, or Smith's criterion. And this is more specific now. So actually, what they further quantified excessive discordance, rather than saying just a bog standard 5 mil. They basically said the ST elevation was too much if it was more than 25% of the preceding S wave depth. So if the S wave depth was 30 mil, for example, you would need to see 7.5 mil of elevation for that ECG to be positive. Okay, so obviously if you took somebody with 5 mil of elevation, they might not necessarily be positive. That's just kind of where modified C comes from. So modified C says that in looking back at this normal ECG, so we're not going to find it in any lead where there's a negative QRS complex. You're looking at the ST elevation. If it looks like it might be more than it should be, then we apply Smith's criterion, which is looking at the depth of the S wave and comparing it to the ST elevation. In this case, there isn't any, and actually I've never seen it, and I couldn't find an ECG example of it. But it's just bearing in mind, if you see a left bundle branch block ECG with really massive ST elevation, it's probably Smith's positive, and in which case, if they look like they're having an MI, they can go to the cath lab as well. So the old Sgarbosa C criteria doesn't qualify you to go to the cath lab. You go to the nearest A&E and work them up using troponins and things like that. If you use Smith's modified criteria, then you can go to the cath lab. Okay. So this example of Sgarbosa A, remember we said any lead where the QRS is predominantly positive or supposed to be predominantly positive if you see ST elevation. So there we go. We've got ST elevation in AVL. You only need it in one lead. You only need to see 1 mil. Off you go to the cath lab if this patient looks like they're having an MI. Okay. Sgarbosa B, again, we said in any of the right precordials, so V1 to V3. So we've got negative QRS complexes. You expect to see some ST elevation and a positive T wave. If you see any ST depression and in a patient that looks like they're having an MI, off they go to the cath lab. And this is positive here. I think that's nice and clear to everybody that there's ST depression where there shouldn't be. And the ST depression rule only applies to leads V1 to V3, just bear in mind, whereas the other two rules apply to any lead. Okay. So again, the Eaton triage tool, I'm going to make this famous one way or another. There might be some of you that haven't seen it from last week. You can quote me, Eaton et al. 2016, I think I wrote this. So any patient that you suspect is having acute coronary syndrome, you stick on the ECG leads and they've got left bundle branch block. Whether or not it's old or new, we don't care. If they're hemodynamically unstable or they're showing signs of acute heart failure, so that's acute pulmonary edema, off they go to the heart attack centre. Okay, if they don't have those signs, but their Sgarbosa score is more than 3, so effectively they're positive for Sgarbosa A, so inappropriate ST elevation where there shouldn't be, or inappropriate ST depression in the right precordials, off they go to the heart attack centre. And then that brings us down to the modified C criteria. So if the STS ratio is more than 25%, that is modified C criteria. Off they go to the cath lab if they're having an MI. If they don't meet any of these criteria, they go to the nearest A&E department. But in both cases, they get an ACS care bundle. So what is that ACS care bundle, I hear you ask? Well, let's go back to our patient. So this was our 50-something-year-old chap that was looking very unwell, and we had some inferior ST elevation. He was looking pretty shocked, and obviously we're going off to the cath lab with this chap. There's no doubt about that. But so this, I'm trying this. I've never used this before. I think this is kind of like 1 or 2 word answers. So just fire them in, and it should paint a little bit of a graph. So ideally, I want everybody to have a go at this if you can. So just put 1 or 2 words. What are we going to do for our patient that's having an inferior STEMI? So talk about places that you're going to go with them, drugs you're going to give them, treatment you're going to give them, things like how are we going to position them, how are we going to, anything you can think about for the treatment of a patient that's having an MI. Wonderful, look at that. There we go. So you can have up to 5. You can have up to 5 words or 5 answers. Look at this. It works. I've never tried this before, so that's good. And hopefully, if you all say the same things, those words get bigger is the idea. And we'll talk through them. Yeah, fantastic. We can use the app. Let's build a nice picture. Well done, everybody. So everybody's going for the morphine, aren't they? Morphine seekers, a lot of you. Obviously don't work in London. Nobody gets morphine in London. Lovely. So if you can, folks, there's people posting in the chat. If you can, then post on the Mentimeter app. But you are all making good things there. So 300 cloppy, 300 aspirin. We'll talk about that. Semi-supine, cloppy aspirin. Check for Visa or MasterCard. That would be the American way. Yeah, absolutely. But that would come first, actually. Personal setup, whoever you are. That would be the first thing the American would do. So it's I won't make any more political remarks about American emergency service workers at the moment. Dual antiplatelets, right ventricular involvement, lovely in the chat. Yes, you definitely do a V4R. Sienna Menti.com, yeah, fab. It comes first for me. O2 if needed, lovely. Good, well done, folks. So let's have a little look in here. So morphine, aspirin, oxygen, GTN, all coming up well there. So oxygen, let's talk about that first. When are we going to give oxygen? Only if they're hypoxemic. So we're only going to give oxygen to somebody if their sats are below 94%, or potentially for patients that we think are at risk of type 2 hypercapnic failure. We're going to let them drop down to 88%, aren't we, before we give them oxygen. Lovely, sats below 94 from John, fantastic. So, talking about everything else, let's have a look. Unfrac heparin, so actually we're going to use low molecular weight heparin, but that's going to be actually in the cath lab pre-hospitally. Nobody gets that that I'm aware of in the UK. GTN spray, lovely, cath lab, brilliant. So PCI is our gold standard for this patient. Nitrates, so GTN again, fantastic. Right ventricular infarct, so we're going to do V4R. Oxygen below 94, access in left arm. Actually, any reason whoever put access in left arm, throw in the chat what you're thinking there, because I've never heard that one. Access anywhere would do. So you want both arms, good stuff. Cath lab like to have the right arm free. Oh yeah, good point. Actually, no, I have been told that. Well done. So yeah, depending on your cath labs, they may have a preference, and they do like to have the right arm free for the, of course, for the going into the radial artery. Good point. So fab, aspirin, we're seeing clopidogrel in there, semi-recumbent position. Obviously, so you're going to get the patient into a nice comfortable position. Ultimately, they're in cardiogenic shock, aren't they? So we want to reduce cardiac output as much as possible. So ideally, we're not going to get them climbing over whatever else. You know, we're going to try and assist them to the ambulance or whatever, wherever we're going with them as gently as possible. Lie them down, get them comfortable, give them all these nice drugs. Fantastic. So everybody's on the right lines. Angiogram, fantastic. Fluids we'll talk about. Yeah, brilliant. Okay, Entonox, I'm going to talk about in a second, Michael. Lovely. So this is the ACS bundle. So okay, this is I built this up over the trust and the places I've worked and kind of general national NICE guidelines and things like that, and RC UK guidance on what we're supposed to do. So gold standard in the UK for anybody that's having an MI. Matt, so once you've cannulated, you can't draw from that cannula again. Yeah, absolutely. So that is one of the downsides of getting loads of lines when you know, it's all right going into the cath lab with 5 lines, but if they can't take blood from any of them, they're still going to have to put a 6th in. So yeah, we generally only put 1 line in, but I'll talk about that in just a second. So yeah, so emergency access to PPCI, so primary percutaneous coronary intervention. And that is a kind of umbrella term for going in there and having a look at their coronary arteries and see what needs doing. So, dual antiplatelet therapy is first line. So, okay, there's a bit of a caveat on, obviously with all of these drugs, just be sure that they're not contraindicated. Obviously, that trumps everything. So, but in most patients, you're going to dual antiplatelet. So you're going to give 300 of aspirin. So a few of you said 300 of clopidogrel. Actually, if you know your patient's going for PCI, the dose is 600. So 600 milligrams clopi if they're going for PCI. There is a time. So if you're not sure, and I don't want to give the answer to the next question away, so I'm being deliberately coy. But there is a time when you would only give 300 milligrams of clopidogrel. But most cases, certainly in the southeast of England, where I work, every patient is going to get PCI. So every patient that's not contraindicated gets 300 milligrams of aspirin and 600 of cloppy. The big difference between the aspirin and cloppy is you can give the aspirin as soon as you walk in the door and think they're having an MI. The cloppy, you need to actually see it on the ECG. You need to have diagnosed an MI before you give it. Fabulous. GTN, everybody I think pretty much mentioned GTN, so guidance is 800 stats, provided they're not hypotensive, and then 400 to 800 micrograms every 5 to 10 minutes. Generally, you find patients don't tolerate it too well for too long. I tend to give 800 at first, and then 400 every 5 to 10 minutes. They generally, after about 3 or 4, they say, no, I don't want any more than that because it tastes revolting. And actually, generally, their blood pressure is dropping off at that point. And yes, you want a little bit of hypotension, but not too much. The reason we give antiplatelets is obviously to try and prevent the thrombus growing in any further size. The GTN we give to reduce cardiac preload and afterload, and also to try and dilate the cardiac vessels themselves to see whether we can get some blood past the thrombus. Analgesia is for patient comfort. This is really, really important. Actually, I think one of the most important parts of what we're doing for these patients. And bizarrely, it's the one we tend to forget about. So grab them some Entonox. Somebody talks about Entonox not being tolerated terribly well in vehicles. You're right. It can make some people feel a bit nauseous, but so can all meds. But Entonox does work very well for myocardial ischemia type pains. But the gold standard is morphine. Okay, so morphine sulfate, 5 to 10 milligrams IV, and then titrated PRN up to 20 milligrams. So one of the trusts I work for says consider a prophylactic antiemetic, but then doesn't give us a very good prophylactic antiemetic. Another trust I work for says don't give prophylactic antiemetic, but yet they carry a very good one. So we could do with combining the rules slightly. Cyclizine is a very good prophylactic antiemetic. Some trusts do carry it, some don't. Metoclopramide failing that if you don't have access to cyclizine. Bizarrely, the trusts that say do consider the prophylactic antiemetic only provide us with ondansetron now, and actually ondansetron isn't very good as a prophylactic. It generally only works once the patient's actually started vomiting. But it's worth considering these patients, and I saw somebody put in the chat there, yeah, so one of the cath lab likes antiemetics. So our local cath labs all give cyclizine if we get there and we haven't given anything. We don't carry cyclizine, so sometimes we give metoclopramide, sometimes we give ondansetron, but it's worth doing. Consider a fluid challenge if they're hypotensive, but the very big caveat of please don't make sure you put them in acute pulmonary edema. Yeah, cyclizine is quite popular. Consider atropine if bradycardic again. So atropine works on the SA node, it takes the brakes off, it removes the vagal tone that we talked about in one of the previous lectures. Just be aware that if you increase heart rate, you're increasing myocardial oxygen demand again. And the whole idea with the MI is to reduce that as much as possible without obviously causing end organ damage. And consider applying the defibrillator pads again. You know, some paramedics will always do this, some paramedics shy away because they think it'll scare the patient. I think if I was the patient, I'd rather know that I had everything in place for if the worst happened, they could just get on and deal with it. And plus, you know, the RCUK do advocate stacked shocks still, or have done for a long time and probably will still continue to. If you have the patient on the pads and being monitored, you can stack shock them, which is a lot better for kind of early onset, the first kind of stages of VF. So as usual, we're running on a little bit. I'm sorry again, guys, but it doesn't seem many people mind if we go over a little bit. So we're nearly there now. So that's the ACS care bundle. The big caveat, as always, is refer to your local guidelines. Not all the trusts are going to carry all of these drugs. Not all these trusts are going to want prophylactic antiemetics. And some of the trusts will say don't give GTN in right ventricular involvement. Some will say don't give fluids in right ventricular involvement. Just be aware of where you work, what the guidance is, and if you do step outside that guidance, just make sure you're backing it up with evidence and knowledge. Okay. So this patient again, so our 50-something-year-old chap who's having his inferior MI and is unstable. So the PCI centre is closed. What now? Chems. I like that. So, okay, I would have laughed at that a lot more before I went for SCAS, because HEMS come to MIs, don't they? In London, if you phoned HEMS instead of got an MI, they'll say, cool, thanks very much for your call. They only go to trauma, for those of you that don't know how London works. So, lovely. Well done. Keep throwing some ideas in there, guys. Do they close? I don't know. It's burnt down. They don't generally close. No, you're right. Although there are probably some, I'm sure in deepest, darkest Norfolk, there are places that close at sunset because they haven't got electricity. And on divert due to COVID, yeah, potentially. Lovely. So we're getting some ideas in there. Find an open one. Your nearest open one's Glasgow, and you're sitting in Bournemouth. There's been a massive outage of PPCI centres. Cardiologists have been taken down by a particular strain of COVID that only attacks cardiologists. I don't know. HEMS, right. Putting on a couple of extra leads to see what's going on. Have they diverted to COVID? Fab. So there's a few of you voting. Lovely. So ED at a PPCI hospital definitely is an option. Find an open one may not always be an option. So morphine. So your drugs predominantly aren't going to change. So what I'm getting at here is the thrombolysis pathway. Some trusts have a thrombolysis pathway for patients that aren't going to get PPCI, and I want to say, I don't know if anybody from East of England is in the chat, but I want to say that East of England still do thrombolysis for MIs, because there are parts of their geographical footprint that where they're too far away from a PCI centre. So if a patient were to have an MI on a golf course in deepest, darkest Norfolk somewhere, they might not be able to get them to a PCI centre within a reasonable amount of time. So that was that. So yeah, so thrombolysis was kind of what I'm getting at. All the drugs are going to stay the same, apart from your clopidogrel, just down at the bottom there. Clopidogrel is limited to 300 milligrams, where the patients are going to have thrombolysis, and that's because thrombolysis is obviously is working in similar ways. It's breaking down the clots. So clopidogrel is an antiplatelet, it's preventing clot formation. Thrombolysis, so tectenoplase itself is a fibrinolytic, so it's going to break down the fibrin and cause the clot to dissolve in effect. You can imagine pumping somebody full of a fibrinolytic is going to have absolutely loads of side effects, loads of cautions, loads of contraindications. So they aren't given lightly. There's normally a checklist you have to go through. I was trying to find an example earlier, but I couldn't, other than a very outdated GR Calc one. But there's normally a checklist you have to go through before you give tectenoplase, and that is the drug that's most commonly used in the, well, it's the only one I think really that's used in the UK. Streptokinase used to be used, but it's kind of gone out of fashion. So tectenoplase 30 to 50 milligrams IV by rapid injection. So retiplase is another one that JR Calc have in their books. So as far as I can tell, tectenoplase is the favoured one. As I say, I've never worked in a trust where we've done thrombolysis. So I was trying to find some guidance from a trust that did, so I could only find the nice guidance, and they say use tectenoplase. Where PCI isn't available, or there's an extended delay, and they kind of edge towards about 90 minutes being about the cutoff. So the key point with thrombolysis is you can only do it within 6 hours of symptom onset. Limit your clopidogrel and transfer the patient to the nearest A&E department. So that's your kind of so lovely. We've got some comments coming through. So what is the thrombosis ice? Begins with E. Thrombolytic that begins with E. I don't know, maybe Charlotte could have a look through thrombolytics, see which one it could be. So retiplase and alteplase, again, in the guidance I read earlier, tectenoplase was the gold standard, but so retiplase and alteplase are both fibrinolytics of the same family, so there will be reasons why tectenoplase was the favoured one. As I say, it's a bit of a, from what I can tell, it's very much going out of fashion. But as I say, it would be interesting to know whether what the kind of the feeling is of paramedics that do this. I would imagine Scottish ambulance and Welsh ambulance will have pathways for this, because again, I can't imagine that there are places there where it's going to take you 2 hours plus to get to a cath lab, isn't it? So no thrombolytic beginning with E in the BNF. Fab, thanks, Matt. Fab. So that's it, folks. Sorry it ran over a little bit again, but that's ACS in a nutshell. SCAS used to thrombolyze, yes. That was probably because I was saying to Charlotte earlier, I remember the SCAS trainers talking about text plays, but they doesn't sound like they did it anymore. So, but yeah, fantastic. Lovely, yeah, good value for money when it's overrunning. So, folks, those of you that don't want to join the Q&A are free to go. Charlotte's just popping up some links. We'd be really grateful if you could leave us a review if you haven't already, those of you that are new to us. We're doing these free of charge, and we'd really like to continue to do them free of charge. The kind of caveat is that you if you leave reviews and things like that, it kind of helps customers come and find us for our paid services, which is really useful. So next week will be episode 5. We're going to look at the T wave, and the T wave can tell us lots about a patient. We've kind of already talked about the inverted T waves and sun leads, giving us kind of pre-warning of upcoming MIs and things like that. But that'll be along next Monday at the same time, 7 o'clock next Monday. If you want to join us live, it will go up on YouTube like everything else. If you'd like a CPD certificate for tonight, or for any of the old ones, if you've watched them on YouTube, then webinars at stctrainingsolutions.co.uk, and we'll get that sorted out for you within the next few days. The PowerPoint slides will go up, and the handouts, I still haven't managed to get around to doing the handout for last week. I'll get that up with the handout for this week as soon as possible. Those will be on our website as the day goes on. And the Q&A session is next. So the review links are in the chat now, folks. If you'd be so kind, that would be really, really nice. And we'll go to the interactive chat where you can post your questions through menti.com, or you can post them directly in the chat, or you can tweet us, you can WhatsApp us, you can email us. Fab, you're more than welcome, everyone. We'll hopefully see you again next week. I was just thinking, I just saw your comment to the brand name beginning with E. I think that was one of Clopidogrel's brand names. There's a. So SCAS, so I'm bank technically at Wickham, but will be doing shifts from Wexham, so in that kind of area. But I based around Uxbridge, so I can move around. But yeah, certainly be interested in doing some work. Come to Milton Keynes. Well, you know, got accommodation up that way, so we might well do. So Michael, yeah, absolutely. It'd be if you want to talk more about that, then drop us an email. We're hopefully doing some training for the LAS on subjects around this. So it would be good to get SCAS as well. So. Wickham PCI, are they a bit notorious? Fab. So, what books do you recommend for ECG study? I've got it. My go-to book for ECGs is this one, 12-lead ECG, The Art of Interpretation. If anyone's interested in that, it's not the cheapest book in the world, but that's my kind of go-to. That was a book I bought during my paramedic course on the recommendation of one of the trainers. And it's been a godsend. It goes into just the right amount of detail on every subject. So that's my favourite. Is there a 3-lead suitable for MI diagnosis? So if you think about that, so personal setup. With that, so you can have a look at the inferior leads, can't you? And you can have a look at the high laterals with your limb leads on. So looking at leads 2, 3, and AVF are 2, 3, and yeah, Charlotte will do that for you, Dan. 2, 3, and AVF look at the inferior leads. You can look at those with just the limb leads on, and of course you can look at 1 and AVL with the limb leads. So you can look at lateral, look at high laterals, but no, you can't diagnose an anterior MI or a posterior MI with just the limb leads, if that makes sense. So that one is answered. Any other questions, folks? No, you're more than welcome. So Michael, they're all on, so episodes 1 to 3 are on our YouTube channel and on our website in the CPD section. So the links are just going up, I believe. The syndrome beginning with S, I missed last week. Oh, Sgarbosa's criteria, Diane. What I might do, yes. So I kind of ran out of time this week, so we've both had quite a busy week. So the handout for last week was going to have a separate Sgarbosa's criteria handout, as it were, like a standalone little card that you could potentially print off and keep with you at work or have on your iPad or something like that. So we will do something specific for Sgarbosa. We talked about it last week and again this week, but I know it doesn't make a huge amount of sense to everybody until they actually start putting it into practice. So we'll do the handouts, we'll put them up on our website. So if you go to the CPD section of our website, and then I think it's catch up. I think Charlotte's put some links up there already, so you can get you can download the PDFs from there, Diane. Obviously, if there's anything you can't find and you want, just email us and we can always ping it back to you as an attachment. Any other questions? I think the rule there is not to sit naked in parks. I think personal iPads is probably a good thing that you're anonymous. More than welcome, John. We look forward to hearing from you. And Diane, there's the link just gone in there now for our CPD page. And you can download the PowerPoint. So yeah, so there will be a handout going up for last week's one and this week's one, and as part of that, we'll do a Scarbosa little cheat sheet. Any more questions from tonight's stuff, folks? If you think of anything afterwards, absolutely fine. Just fire them to webinars@STC or tweet us, text us, any of the above. So, Michael, where do you work? Because if there's going to be cake involved, then Milton Keynes. Okay, is Diane Milton Keynes as well? So I've got to do some third manning shifts. So shall I come to Milton Keynes and we'll have cake? Oh, Diane makes cakes. Fine, okay. I think I know where I'm booking my third manning shifts. Oh, that's good to hear. Thanks, Michael. Take care. See you soon, probably. You're welcome. Take care. Hopefully we'll see you all next week. So, doesn't look like there's any more questions coming through. So there's our website, as I say. And of course, if you or anyone you know is interested in any of the upcoming courses, then do give us an email. Fantastic. So I certainly can. Are you doing certificates already? Yeah, fine. Okay, folks, so there are no further questions then. As I say, anything else you think of, pop them in an email to us. We'll respond during the week. And you are more than welcome for everyone that's saying thank you and good night. So you're more than welcome. We'll see you again next week. And we hope you have a good week. Enjoy the weather we're getting at the moment and reduce lockdown. And we'll see you then. So we'll stop the recording there.